And there's that classic thing of, when you're on your deathbed, will you regret kind of be like, oh damn, I wish I'd been a consultant 2 years earlier. Or will you regret, oh damn, I really wish I'd taken that kind of trip around the world that I wanted to do, but I just never got around to because of my training.
Hello and welcome to our podcast Pager. I'm George Milner.
And I'm Stan Dale.
Tune in to hear us talk with some amazing people about the subjects changing medicine today.
From stem cells to mapping the brain and medical ethics, we hope to give you a glimpse of the bright future ahead through discussions with some of the people making it happen. Hey everyone, welcome to this week's episode of the podcast. This week was a bit different. We spoke to Ali Abdaal about how medical education is changing. Now, Ali's a junior doctor in Cambridge and a graduate of the university, and he's really well known for his YouTube channel, where he talks about everything from productivity to technology to medicine. And we ended up talking about everything from career planning to sort of reevaluating your priorities. We split the conversation up into two parts, but the second part is really just a continuation of the first. We really enjoyed recording it, and we hope you enjoy it. All right. Okay, and we're here. Ali, thank you so much for joining us on the podcast.
Nice, thanks for having me. This is an absolute honor.
So we were quite surprised when you approached us and said you'd like to come on our podcast.
We humoured you in this case. Yeah, it's a big deal, especially the fact that you're recording like within the heart of the Cambridge University. It's like, I've got these fans from all across the world who look at Cambridge as being like a big deal, and therefore kind of being able to kind of sit here recording with you guys.
It's podcast.
It's really a dream come true.
The world.
Yeah. How much time do you actually spend in the centre of town? Sorry, this is completely not how I start.
On average, about once every 2 weeks. If I've got a random day off work, I'll come over, have a cheeky latte in Jamaica Blue, do a bit of work, mark some physiology essays, which I'm still like 3 weeks behind on.
So yeah, we thought we'd start by talking a bit about medical education, which is obviously something
love it.
You know quite a lot about.
Well, I don't know about that, but...
Yeah, and so one thing that's always surprised me going through school and then higher education is that we're never really taught how to learn. And I still know a lot of really clever people who just brute force their way through revising for Tripos. What do you think about this idea that we should be taught how to learn insofar as you can be taught how to learn some point?
It's like the most important thing. It's like, so I don't know if you guys had this, but in second year, do you still have those like weird optional bits at the end where you can choose between like psychology and like a bit of pathology and a bit of, or have they scrapped that?
No choice anymore.
Oh, no choice anymore. Oh, okay. Because like, back in my day, a few decades ago, there was like this like extra component of second year where you had to choose 2 out of 10 optional modules. And one of the ones that I chose was experimental psychology. And in that we had a lecture called How Memory Works or something like that. And the whole lecture was about these things like active recall and spaced repetition and why rereading is a bad idea and why making notes is not very useful and all this stuff. And like, there were like 80 of us in this lecture and we all walked away from that thinking, damn, this is some good shit. Sorry, are we allowed to swear?
Yeah.
Cool.
Yeah, we've got full control over the podcast.
Perfect, we can beep that out. And we were like, why has no one taught us this before?
Right. I mean, that seems like the sort of thing people should be taught the first week of first year.
Yeah, exactly. I was even thinking that, it would, like, I was planning to just put on like a lecture at the start of the year being like, if anyone wants to learn how to study for exams, that, come to this. But then I thought, it'll be more scalable to turn it into a YouTube video.
Or even earlier on. I mean, throughout your school years and things like that.
Yeah, true. And one of the cool things that of kind of doing the YouTube thing is that I get occasional comments from teachers and stuff saying that, I played your how to study video in my class and everyone loved it. And now they've started, testing themselves more rather than just rereading their material.
I mean, the fact that you say that speaks to something else I think about higher education, which is that the really useful resources for learning aren't necessarily where they used to be, if that makes sense.
Oh God, yeah. Everything's online these days. It's like if you want to find something, you search YouTube and then you search Google and then you maybe look at a textbook if you really have to.
Well, let's dive a bit into that. I mean, there's things like edX out there now where you can take online courses, particularly for subjects like data science and computer science, which will teach you everything you need to know about that course remotely.
Yeah.
So how do you think places like Cambridge, other universities are going to have to change?
So I think Cambridge should do what MIT has done and start open sourcing the kind of lecture material. Because like MIT is famous because their like computer science course is all entirely available online. You can just take it. And so many people, for some reason, look to Cambridge as being like a leader in education, even though, as we know, the ranking of university is more based on its research output than on its quality of teaching. But still, when someone says Cambridge University medical student, you're like, oh, damn, your teaching must be really good. And then you kind of feel like, I kind of feel bad saying that. I mean, yeah, some of the lectures are all right, but I, just fell asleep in half of them and didn't turn up to the other half. But I think that because of the brand, it makes a lot of sense to just put stuff online out there for free. And I've tried doing this with the clinical school sometimes. I try and get them to be like, hey, why don't you put this video online? And then they all say, oh, well, we want to have it behind our student login because what confidentiality, and, the only consent we've had from our professors is so that students internally can see it, and all this sort of stuff. And I just feel like, oh, come on.
It seems like an excuse, really.
Yeah, I mean, where there's a will, there's a way. If they were really keen to have a Cambridge University medical school YouTube channel, that would do great. Like, literally just put loads of material on it and people would love it.
And I suppose the question that then gets asked, it's a bit different for a vocation like medicine, but for some degrees, why do you need to come here for the degree anyway?
Yeah,
At
true.
a certain point in time.
Everything could just be online. It's glorious.
Yeah, I mean,
what a time to be alive.
Yeah, I mean, what would that even mean for higher education?
Well, if you can if you could pass a Cambridge medical exam, should you get a Cambridge degree at the end of it?
Yeah, well, that's a good point. I don't know, really. I'm not sure about this whole degree system, right? Because what is a degree really? It's just like a badge that effectively you've done a few exams, and you can pretty much get the Cambridge degree without having turned up to any lectures. And I'm sure a lot of art students do that. When you have one lecture a week, you can just not turn up and just do the exam.
And a few scientists as well, actually.
Yeah, true.
I guess it's a badge that you knew part of a collection of stuff at one point in time, not necessarily that you know in the future.
No, exactly.
If you look back to our first year anatomy, I think that'll be evidently clear.
Or even first year, mate, I'm having to revise really hard for these physiology supervisions that I'm doing now, and it feels like it's all new information. And I'm like, oh damn, this is all starting to make sense. And I knew all this stuff at one point about the medullary hypotonicity and countercurrent multiplication, all this stuff. And I'm like, whoa. I feel like I'm understanding it from first principles again.
I suppose one thing it does speak to is the ability to manage your time and the ability to deal with a certain degree of stress, which are useful things for getting a job.
Yeah, I suppose. Yeah, I guess.
So maybe it's showing different things to what we ostensibly say it's showing. Maybe.
And I guess for us it's different because of the medicine being a very vocational thing that, whereas, doing an English degree or a history degree or whatever, I think maybe it's more about the university then. I don't know. I'm just chatting breeze here because I don't know anything about other degrees other than medicine.
Well, let's talk a bit more about medical education specifically.
Yeah, and I guess there's a big question over whether we should be learning facts or skills or a combination of the two. What do you think about this?
Facts or skills? What do you mean by skills?
I mean skills as in approaches to solving problems that aren't necessarily dependent on knowing one piece of information in time. For example, I take a skill to be, I know that active recall works for me in terms of learning things, and a fact, this drug does this.
Oh, okay. So the way I started thinking about this is sort of like a Venn diagram of kind of, if you imagine three sort of circles with an intersection in the middle, and then there's one circle which is things they teach you in med school, and then there's another circle of things they test you on in med school, and then there's another circle of things that's useful to be a doctor. And there is such a small amount of overlap between those, which I think is very sad. And there's also an annoyingly small amount of overlap between the things they teach you and the things they test you on. At least when you get to clinical school. In undergrad, it's a lot more holistic because everything they test you on is in the lectures, basically. So when it comes to medical education, I think at the moment there is such a huge focus on memorizing a ton of material, even though and it hasn't quite moved beyond that point to realize that actually I've got the BNF on my phone. I can look up a drug dose whenever I want. And therefore, what sense does it make for me to have to memorize that drug dose? If that makes sense.
And also it could be counterproductive if in remembering all those drug doses actually you're not focusing your attention on something else, then actually you might be a worse doctor because of it.
Yeah, absolutely. And this is one of the things that annoys me about the exams. I'm looking into taking the USMLE these days, and there's just so much tiny little bits of detail that are so totally irrelevant to actually being a doctor. But hey, it's the game.
It might
that we
actually
play.
change in a year, 6 months, 10 years.
Exactly. As soon as someone discovers something new, then okay, that receptor doesn't do that thing anymore. Not like anyone cared in the first place.
I suppose the obvious follow-up question from that is, what are the things which overlap? What actually is useful? What are you using as a doctor that you learn in medical school?
So I think the most important thing is the diagnostic skills, because for example, if you're seeing someone with chest pain and knowing about the fact that aortic dissection is a thing is really important, because when you're thinking about it, then you can rule it in or rule it out. If you don't even know it's a thing, then you'll obviously miss it. But then I think beyond that, the management of aortic dissection, sure, in the immediate setting, it's helpful to know off the top of your head, okay, right, this is what I need to do. I need to do an ABCD approach. I need to stabilize the patient. I need to call for help. I need to do a CT aorta to see whether, what's going on. But then in terms of management, then it becomes a lot more pointless, I think, to memorize what to do, because at that point, every hospital has different guidelines. you'll be asking a senior anyway, and at that point you can very easily look it up. So I think diagnosis and emergency management of things are really the only things you need to have in your head, whereas everything else can easily be looked up, and you'll be far more up to date based on what you look up rather than what you memorized in med school 8 years ago.
But on the other hand, could you say there's some degree of merit in roughly knowing things, so actually you can kind of fact check the checklist that you're going through in the first place, and actually it takes kind of a medical education to look through the BNF and work out what's relevant and what's important for that situation?
Yeah, that's a good point. And I think like there's a big part of the way I try and think of it is sort of like layers of abstraction in a way. So it's like when you're on your Macs that you've got in front of you, you know how the computer works and you know how to do stuff, but you probably don't know what happens when you press the on button and what binary gets compiled and all this stuff.
You're treating it like a black box.
Yeah, exactly. It's a black box, and you're kind of taking the bit that you need to worry about and being like, okay, I know how to do this thing. And so you're operating at a very high level of abstraction when you're operating your computer. And I think it's the same in medicine, that we get tested on the granular level of detail, but then in real life, we actually don't need to worry about that granular level of detail. We kind of abstract that away. And so for me in real life, how the kidneys work isn't overly important in terms of the receptors, but it is roughly important that I know what the kidneys do, and the fact that, constricting the afferent and efferent arteriole does different things to your blood pressure. And that would be sort of the basic level that I'm operating at. But I think that in medical education, the fact that I had to learn it from the ground up, from that binary thing, does make it easier to then forget those bits later on and kind of abstract that knowledge away.
I guess we take this one step further. You're an F2 right now, in second year of being a junior doctor. And as you get into being a specialist and you specialise even more, and actually there's perhaps areas of the body that you're never really going to go near again.
Oh God, absolutely. Yeah, there's like orthopedic surgeons who specialised in the left toe, for example. And they're like, why do I need to know about how the heart works? It's like, well, fair enough.
Yeah. So I guess from this, could you train somebody, for example, to be an orthopedic surgeon who specialises in the left toe in a much more streamlined way? Or are there kind of overlaps for being a specialist?
Yeah, my counterpoint to that would be that it might not even be for the patient's benefit, the future patient's benefit, that you're learning such a broad set of skills. If you do just become an orthopedic surgeon, it's for your benefit, because you don't know what necessarily you're interested in right out of school, do you?
Yeah. No.
Yeah.
So George, your question wasn't particularly very good.
it's actually on that point. So actually on that point, one of my friends who was at Emma in my year, his granddad was the president of the Royal College of Surgeons of Edinburgh at one point. And his granddad apparently used to say that there is absolutely no point in surgeons going through medical school, because, as you said, when you're specializing in the left toe, you really don't care about, how the Krebs cycle works, for example. And the whole thing about, there's a shortage of doctors and medical training is too long and too expensive, all of this stuff could be solved if we sort of made the training more focused from day one. And so, like, okay, if you actually want to be a surgeon, then these are the things you actually need to know to help with that. But this guy's granddad's theory was that that's never going to happen, because it requires a sort of 5-generation change within medicine, and no one is going to think that far ahead and be brave enough to propose that as an option.
Or maybe not that people would specialise kind of initially into surgery, but perhaps there'd be, I don't know, maybe 4 groups of kind of doctors that you could potentially go into.
Yeah, something like that. Yeah, so you can kind of tailor it accordingly on day one, or it would be good to have the option of a broad general medical education. But there are certainly some people who are been desperate to become a cardiothoracic surgeon from the age of 15 onwards, and so for them certain bits of the body might not be as useful as others.
And I suppose this makes me wonder, to what extent are some medical jobs technical? You're acting really just like a technician, in that you have a bunch of tools to solve a problem, but it doesn't really involve that much thought. And I wonder if there are some areas of medicine which are more like that than others.
Yeah, I feel like kind of being a junior doctor in general, there's not much of it that requires lots of thought outside of the diagnostic part. That's the main thing, where, you're getting a list of signs and symptoms and talking to the patient and exploring their concerns and blah, blah, blah. And you're coming to some sort of conclusion about what's going on. But then beyond that point, a lot of it is fairly kind of following the guidelines very, very specifically. I'm doing obstetrics and gynecology at the moment, and there are sort of guidelines for absolutely everything. It's like basically a flow chart that you can follow. When you get to kind of higher up levels, where sort of you start getting into the gray areas and you start having to use your judgment to make decisions, then I think it's a lot more important to have that broad educational base.
How much of that is there in at F2?
Not a lot. It's mostly following the guidelines. If you're on call overnight and you're looking after like 20 patients and someone becoming acutely unwell, then at that point, even then you're following an ABCDE approach. You're kind of doing the basic things that anyone could do. You're not really thinking about, okay, let me think about this composition of this particular fluid and how that's going to interact with the loop of Henle. And you aren't really thinking at that level of detail.
Although I can tell we're slightly moving away from medical education.
Yeah.
So
Well, I was going to ask, do you think this will change in the future, actually, as we can only get kind of more guidelines, as perhaps grey areas become less grey? Do you think actually doctors will do less thinking?
Yeah, I mean, I think it's good if doctors do less thinking, because in general, you don't want a system to operate based on the amount of sort of based on the intellect or the understanding or the knowledge of individuals in the system. And I've been reading a lot about like business management and stuff these days, how to scale a business and things. And there's a really good book called The E-Myth, which is all about like how to kind of grow a small business and the challenges associated with that. And they use McDonald's, the franchise McDonald's, as an example of how to do this well, because McDonald's is so well systematized that it's not at all dependent on the individual's kind of showing initiative or anything. It's literally a system, a series of checklists for absolutely every single process. And that's why you get the same experience at a McDonald's in, I don't know, Ghana as you would in a McDonald's in the US, because it's so well systematized. And I think that's how an ideal system should be built. It shouldn't be reliant on
it removes the room. It removes the room for error, I suppose. The human error.
Although I guess the perhaps one risk with this is that people start kind of applying guidelines and algorithms in situations where they aren't necessarily designed to be applied, and we see it kind of all the time with artificial intelligence suddenly being transferred to a new problem. So I guess we have to be taught when to use particular guidelines and particular scenarios, and that might not necessarily be as clear as it is on the top of the guideline.
Yeah, and I think like from my perspective, I'm still very junior as a doctor, and so a lot of what I do feels like it's following a guideline. Whereas when I look at the senior registrars and the consultants, a lot of what they do is kind of going beyond the guideline because they understand that actually, these are the 12 studies the guideline was based on. This particular scenario doesn't fit nicely into any of those. Therefore, I'm going to deviate from the guideline because of this. So they have a much clearer understanding of what the grey areas are and what to do about it, which I think comes from experience and knowledge.
Yeah, and I guess when these deviations from the guidelines occur, how good are people and what kind of structures are there in place for people to actually share that with everybody else in medicine?
Oh, that's a good point. Yeah, I think like if it's like an interesting case, then someone might write a case report, or if it sort of feels like something that's big enough to be able to be published, then they might turn it into a paper. But beyond that, as far as I know, there isn't really a forum to share this sort of stuff, especially because medicine, very rightly is all evidence based, and there's not a lot you can't really be like, well, I had one patient who this worked for. I suppose that is what doctors do when you get to the senior levels, when they're kind of calling up their mates for advice and second opinions and stuff. At that point, your N=2 sample size that this thing worked on might be helpful. But like, at least from my understanding, it feels like a very kind of, I happen to know someone who might have dealt with this thing, so let me ask their advice, as opposed to kind of a general sharing of knowledge type system. And
do you see kind of examples in hospitals where actually most people don't follow particular guidelines on things, and actually they're slightly obsolete and haven't been updated?
I don't think I do it at my level, because it would take a very brave F1 or F2 to actively deviate from guidelines. But I'm sure it happens at other levels that I'm not yet familiar with.
Have you heard of? I'm curious. Have you heard at all about value-based healthcare as an idea?
I've heard the phrase. I don't know what it means.
Okay, the idea is basically, instead of looking at you're really instead of designing a medical system to deliver volume of service, you're looking at the quality of the outcomes and trying to restructure basically healthcare teams around that. And the idea is you then have people who are working on individual patients from very different backgrounds, if that makes sense, medically speaking. So you'd have somebody would come in with back pain, to like the back pain clinic, for example, and you'd have orthopedic surgeons and physiotherapists there together so that they can more easily transfer from one person to the other if one can't help the other, if that makes sense. Sorry, if one can't help the patient. And a big idea in this, a big idea that underlies this is that management skills are going to be really important in medicine. Do you think that doctors should be taught more about like management? Because it seems like at the higher levels, it is a lot of managing people and resources.
Yeah, I think at the high levels,
like a
definitely.
Very roundabout way of saying what I was trying to say, but we got there in the end.
Yeah, no, I think at the high levels, it's definitely much more important. And this is something that I didn't really think about at all when I was in med school and kind of in my F1 year, because I just thought, oh, management, like what's all this BS anyway? Who cares? And now kind of speaking more to consultants who do the management side of things, and like just how much of a job of a consultant is managing people and managing the politics and the systems and stuff. I think it's a skill that's worth teaching. And I guess in the past, through kind of running my side business and stuff, at the start I always kind of thought, oh, who cares about management? It's all about execution and doing the thing well. And as that grew and kind of scaled beyond what I personally could do myself, at that point I started to realize, this management thing's actually quite important. So now I've started listening to podcasts and reading books about management, which is something that I never thought I'd actually be doing because it just sounds boring AF. But now, yeah, I think it's really important for people to develop those skills as they go into those positions.
And I guess with the risk of offending Adam Brooks Hospital, do you think there are enough doctors in very senior management?
Oh, I don't know enough about what the management looks like at Adam Brooks. I haven't really paid enough attention to it. But
yeah, I wonder what actually would be the useful skills. Like when we say management for a doctor, what would actually be useful?
I don't know. That's something I'm trying to figure out, because there's all these management books about kind of like leadership and delegation and how to run meetings and how to do kind of one-to-ones with your employees and how to motivate people and all this stuff that seems very wishy-washy on the surface, but I guess is actually very important. And then there's another big part of it that's like systems design and kind of how to build a system that's not reliant on individuals.
Yeah, and I guess motivation, coming back to kind of the NHS, is so important. We've seen kind of really small things can lead to massive drops in motivation, or actually quite significant increases in motivation. Do you see this kind of on a day-to-day level?
Yeah, I do. I think motivation is very particularly important with sort of at least the doctors that I speak to on a daily basis, because we don't have that thing of you're making loads of money as an intrinsic motivating factor. And so I was speaking to some doctors about this yesterday when I was on call. We were talking about this kind of UK versus US thing. And I made the point that in the US, the quality of life for a doctor seems to be higher because you get paid more, you get more valued, the hospitals are shinier and fancier and stuff. Whereas in the UK, it's more of a culture of, I'm taking the sacrifice because I'm a good person and I'm going to sacrifice my own quality of life for the sake of the system. At least that's sort of the vibe that I get.
But I think there's an odd mythology around this. Do you know what I mean? Like how much does that really reflect the reality of being a doctor? And you spoke about this at your talk that I went to the other week. Is that really the experience that doctors have in terms of job satisfaction? Is that what they feel like they're doing?
I don't know. Like most of the doctors that I sort of see on a daily basis seem to not enjoy their jobs as much as we hoped we would enjoy our jobs when we were sold this dream of, go to med school, you'll have a great job. I don't know. It's hard for me to speak to the experiences of other people, but that's just the vibe that I get.
And what does that say about the component of a medical career, which is delaying gratification, right? What are we delaying gratification for?
Exactly. Like I was speaking to one of my other F2 colleagues about this over dinner yesterday, and she was saying that because at the moment we're coming up to this time where everyone's going for job interviews and deciding whether to embark on core medical training or core surgical training or become a GP or whatever. And it's very much like sort of once you step on that conveyor belt, then it sort of spits you out the other end as a consultant. And if you don't think about it very hard, then you just end up being a consultant. You're like, okay, cool. And so what she was saying is that, I was thinking of taking a year out of medicine, but then I feel like I wouldn't be making any progress. And I was like, okay, what do you mean by progress? And she was like, I don't know, just taking my exams and, getting further ahead in training. And I was like, okay, I mean, like, to what end? Like, what's the point? She was like, because then I'll be a consultant. And I was like, okay, and then what? And she was like, I don't know. I just won't have an exam to take. It feels like a very, like, almost the default path is progression for this arbitrary thing of, quote, being a consultant. And somehow hoping that that's going to make us satisfied.
I think it's so easy to start tunneling without really giving too much thought to, where I'm actually trying to get to.
I think so, yeah.
It's strange. I seem to see kind of two different schools of thought amongst medical students. One is that because it's such a long training process, I wouldn't want to take any time out because I felt like actually I'd be behind in it. And I guess the other school of thought is, because it's so long, I might as well take time out and I'm in it for the long run. This is my life. I can't necessarily live it as a means to an end.
Yeah, exactly. I'm very much, as you can probably tell in the latter category. Because what difference does it make if you're a consultant at 40 versus a consultant at 45? Like, no one actually cares.
I think I'll also
5 gap years.
Exactly. Yeah, it's glorious.
I think I'll see you guys on the scenic route there then.
Yeah, no, absolutely. And there's that classic thing of, when you're on your deathbed, will you regret kind of be like, oh damn, I wish I'd been a consultant 2 years earlier. Or will you regret, oh damn, I really wish I'd taken that kind of trip around the world that I wanted to do, but I just never got around to because of my training.